All right, guys, you guys are live.
All right. Awesome. I don't know. It might be. Okay, so I guess it's over there. I won't be able to see him. So, all right.
I can see both of you. Yeah.
Awesome. So I'm here with Nick Lombard from Dyer Physical Therapy. And so today's topic, we want to talk about how physical therapy, and Dr. Ruziev, how physical therapy services can help you unlock your potential. So, with Nick here, perhaps you can give a little bit of an introduction, who you are, kind of your background, how you got into, doing what you do.
Yeah, my name is Nick Lombard. I'm originally from the Scranton, Wilkes-Barre area up in northeast Pennsylvania. Went to school at Misericordia University, small Catholic school up there. 6.5 years there. And then I managed to make my way down here. My wife and I have been married for about 1.5 years, living down in Ephrata, and I have working over at the Dyer in Lebanon. Been there about 6 years, and I managed a clinic there about 6 to 8 months ago. Things are going well. And it's a great clinic. See a lot of different diagnoses, a lot of different personalities. So keeps everything interesting.
Awesome. How big is your team?
We have 5 clinicians, including myself, and a couple office coordinators, a couple techs. Yeah.
All right. You do occupational therapy, physical therapy?
Yeah, it's just physical therapy that we have at that clinic. There's some other clinics out near Harrisburg, Mechanicsburg area that we do occupational therapy.
All right. And your office is very close to the urgent care here in Lebanon, right? To the LGH or Penn Medicine urgent care. Yeah. So, all right. So, I wanted to ask specific to, we help people lose weight. We deal with obesity, of course. And so, what complications or issues are you seeing in treatment experiences?
This
cracking me up. Yeah. So, what complications or issues?
Part of the presentation.
Yeah. So, what complications or issues are you seeing in treatment of, that are due to long-term effects of being overweight and obese?
Yeah, we see a variety of long-term effects from the obesity and being overweight. Can include contributions to low back pain, knee pain, hip pain, and other things related more to just immobility and deconditioning, which can affect how somebody is able to complete their activities of daily living. And we see that more so in, I think, the senior citizen population, how obesity can affect your general mobility. It also plays a large role in joint replacements now these days.
Absolutely, you agree.
Yeah. So you have some people who have aggravating hip pain, knee pain, who need their joints replaced because of arthritic changes. They're having difficulty getting that covered by insurance because their BMI is too low.
Isn't that interesting? Okay.
Yeah. So it's like a catch-22 there. For them, to have the ability to be a little bit more active to lose the weight. The pain is certainly contributing to that difficulty to do so.
Mm-hmm.
And that's where you guys come in to kind of certainly educate patients, even more preventative than anything too.
Just like you said, even insurance is an issue now. Even some orthopedic groups are making a requirement for you to be able to lose some weight before you actually join a program or whatever.
We've noticed a pretty big uptick in that. I'd say over the past 6 months or so, that patients have been coming in saying, that they need to.
The ortho is requiring them to lose weight
exactly.
before, which is kind of difficult because, you have pain, you can't really move, mobility is an issue, and then you're required to lose weight before you can address it.
And, now that we have a good relationship with you guys, it makes it, a lot more, the continuum of care is there now. I have somebody that I can, turn these patients to.
Yeah. Definitely more streamlined.
Yeah, sure.
Yeah, so, it's kind of interesting what you talk about there, which is, and that's kind of one of the things that Doc and I are passionate about, and that's preventive medicine. And so that's the whole thing. So a lot of times people are coming to us, they're overweight, they're obese, and maybe they're not at the point where it's creating much of a health problem yet, But downstream, what you're saying is, as they get into their older years, of course, it can severely limit their mobility. But even before they get to their senior years, the joint pain starts, the
Sure,
back
yeah,
pain
yeah.
starts, the knee pain starts.
Could be, anywhere from teenage years to 30, 40, 50. It affects everybody.
Yeah, it's interesting, and I think that's where there's the whole healthy at any size kind of movement out there, and I think it's absolutely great to embrace yourself as you are, to have a healthy self-image, and to be happy where you're at. I think that's a wonderful thing. At the same time, I think it's also reasonable to recognize that, physiologically you are doing damage to your joints. I mean, our bodies are not designed to handle, the weight that we're carrying around now. And that's a more recent phenomenon in terms of its, how widespread it is.
Yeah, not just your joints, but when you think about your whole, cardiovascular system.
Absolutely.
There's so many different comorbidities that are associated.
From flu to
Yeah.
cancer, I mean, there's almost no topic that it doesn't touch. It's just think of like smoking; it's right up there. But smoking, smoking does damage. It's the same thing. All kinds of cancer, by the way, more in females.
Yeah, if you look at risk factors for just about anything, that is, obesity is right up there.
Yeah. So it's interesting. I mean, specific to physical therapy, of course, you're getting a lot of the back pain issues, back strains and injuries, knee pain. Probably injuries that were exacerbated in some way by the extra weight. So what are some of the ways that physical therapy can help people that struggle with overweight and obesity? I think we touched on a little bit where, hey, I have pain, it's limiting my ability to exercise.
Yeah.
Moving is part. It's not the entire process, but moving is part of a healthy weight loss program.
Sure, yeah.
Maybe you can talk to us about how physical therapy helps people with that.
So, education is a big component to it, and you guys do a lot more in-depth things than I do and know about. But just with regards to pain, if a patient comes in to me and say, "Oh, my back's killing me, my knee's killing me, I can't go on my walks, I can't go downstairs, I can't do this, can't do that," and a lot of times, unfortunately, they come in too late. Now, I wouldn't say too late, but what I mean by that is, they come in when it's already super aggravating, and they're already super deconditioned, or, the pain's at 8 out of 10, and, it would be a little bit better if they came in, say, a year ago, when their pain's 4 out of 10. And maybe you prevent that 8 out of 10 for, years down the road. So I think with us, getting the word out to come in sooner rather than later will be, better for them. It's better for the insurance companies too. With more conservative care.
Duration and intensity of therapy will be less if they do come on.
And outcomes are better the sooner you can address a particular issue.
I think it's a chronic thing. I think it's safe to say a lot of doctors and other providers of care would agree that care generally in the United States is very heavily concentrated towards downstream intervention versus upstream. And that even starts with insurances. It's kind of insane.
I think there's a couple different factors that play a role, play into that, and I think just some people need to take a little bit more proactivity to these things, because ultimately, you have to acknowledge what's going on and take a step forward before anything can kind of start, which I think is a good, first step that some people don't do.
Yeah,
So,
I agree 100% with that.
So to recap, there you're saying, hey, we can help you, and in fact, you're going to get better outcomes if you come to us sooner, as opposed to waiting till you almost can't stand it.
Okay.
If you wait till you almost can't stand it, yes, you're there to help.
And that's where I'd say 75% is
Of your
at
clientele.
that point.
Have reached that point. But it's going to take longer. It's going to take more sessions. It's going to be more costly, and even the outcomes that can be expected maybe are not as good as if they had come to you sooner.
For sure.
Yeah. And what's interesting with that too is it's very true with obesity and overweight as well. The longer it does accelerate joint damage, in particular I know with the knees and hips, it accelerates joint damage. And that joint damage, as I understand it from the current research, is even if you lose weight, which your pain will get better when you lose weight. It will. And we see that with our clients all the time. The pain gets better. But the damage that has been done remains.
Yeah,
it's irreversible. And so it's one of those things, just like you're saying, the longer you wait, the worse the damage, and then the less optimal the outcome. You know, because some damage is permanent. You know, that's just how it is. So, yeah. So, all right. The next question I had was, when should somebody seek you out as opposed to pursuing a fitness program on their own or with a personal trainer? So, of course, I'm a certified personal trainer. I do personal training for our clients. But there's times where it's not appropriate for me to give somebody an exercise program. And I will say there's clients that I have had where I refuse to give them programs, and I've seen other personal trainers give them programs in spite of sciatica, you know, for example, in spite of very clear, active injuries. You know, some trainers are still willing to give people programs and push them and work them, and then in at least one recent case, it led to a much worse outcome, you know, for that person.
Yeah, I'd say patients with like moderate or higher complexity with regards to medical history, patients who have had some sort of orthopedic surgery in the past, or just, it doesn't just have to be orthopedic surgeries, but or patients with some sort of pain, you know, that's exacerbated with regular exercise. You know, because you do have to modify programs, you know, based on this, you know, information. So I think, you know, getting a subjective history from the patient, examining them, and really, you know, diving into what's going on will certainly help you develop a safe, individualized program for them that'll be very beneficial for them.
Yeah. And when is it and when is it absolutely like, hey, you should not be working with a personal trainer? Like, when would you, as a physical therapist, highly trained in specifically injury rehab, that kind of stuff, when is it like, hey, if you're a person out there, do not start your own exercise program. You do need to go see a physical therapist before you start.
Yeah, I'd say somebody who has aggravating pain with exercise needs to see somebody prior to continuing. So they don't, you know, make things a lot worse, and then, you know, take 8 steps back before they can take a step forward.
Yeah.
And what modalities is available? Let's say just like we live in Lebanon, so in Lebanon area right now, they would come see you for pain.
Yeah. So we take a pretty good, I guess, diversified approach. Modality-wise, whether it's heat and electric stim, I use that in some cases, but generally speaking, I'll use that sometimes in cases that are a little bit more severe, that have a lower tolerance to some sort of activity, just to kind of calm things down a little bit. Because their tolerance isn't really up there to do a lot of things. But then, you know, I like to shy away from modalities, a lot of hands-on treatment, exercise progression, things like that. But yeah, we have the electric stim, the heat, we have vasomimetic devices for swelling, ultrasound in some cases we use.
Nice.
We find that works pretty well with tendinopathies like a lateral condylitis and stuff. But besides that, I don't really use it too much.
Got it. I guess it's a good thing that, you know, Dyer Physical Therapy is a bigger organization, so you have access to those things.
Yeah.
Yeah, Dyer PT. How big is Dyer PT? I know you have facilities in York, Lebanon, Baxter.
I think nationwide. I think it doesn't fall all under Dyer. Okay. So we're part of Upstream. So Upstream is our parent company, and then there's Dyer. But in this area, and I mean, there's one in Lebanon, there's Palmyra, Hershey, York, a couple in Harrisburg. Cool. I mean, there's some in Delaware, there's Virginia. I'd say around the country, there's 1,200 clinics, roughly.
Awesome.
Yeah. Within the Upstream company.
Great. So, if somebody needs, you know, maybe somebody's listening to this, we're going to share this video afterwards. It will remain on our site for a long time. And so they're like, well, you know, maybe I do need a physical therapist. My back's been bothering me. I've been avoiding exercise. My knee's been bothering me. I don't walk very far because of it. You know, maybe I do need to go and see one. What's the typical process involved when clients want to seek you out?
Yeah, so there's a couple different avenues for that. One is you can just search in Google Dyer Physical Therapy in Lebanon, click on our website, and there's an intake form on that you fill out, and then myself and our office coordinator will get an email with your information, and then we'll follow up with you. Or, if you're going to your physician or a nurse practitioner, any healthcare provider, talk to them about what's going on and just ask for a referral for physical therapy, and then you can ask for us for Dyer in Lebanon. Or you can just call our clinic. You can find that right on Google, the phone number, yeah.
So a question I would have immediately then is, let's pretend I Google you, I feel like making an appointment with my doctor, I'm pretty busy, so I Google you, I fill out your intake form. What is required, to get insurance to cover it? And of course, every insurance is different, I'm sure.
Yeah.
But if I just went directly to you and I have insurance, would I be able to get coverage, or do I have to have a doctor's order?
So doctor's order is easy, and then and a lot of physicians are super open to it. Just call or stop in. Yeah, it's great. As far as insurance coverage, we'll gather that information along with the intake when we call you, and we'll, as a courtesy, we'll look up your information, and you'll have an idea of co-pays or co-insurances. So the patient doesn't go in and not know what's going on financially.
So they have bill.
Yeah, exactly. So you'll know on the first or second visit what your financial responsibility is, which is important. But without referral, I have my direct access license, so I can see patients for up to a month without a physician's referral.
Gotcha.
And after that,
After a month, okay.
After 1 month, I'll need a physician's referral.
Absolutely.
So I think it's good to know, because I didn't know that personally. So, people can actually go directly to you.
Yeah.
You can directly get coverage for them for up to a full month. Buy some time, and if they need longer than that, they can get a physician order.
Patients, and they can stop by the clinic whenever they want to, and just talk to one of us. We've had a variety of patients come in who have questions about their knee replacements, or I'm having this issue, like, what do I do? And just being there, and not just myself, any of the other therapists there can help kind of answer questions, guide your process. Yeah, so it's convenient and helpful for sure.
Awesome. So, how about communication? I think that's one of the reasons why we liked, the concept of working with Dyer Physical and you guys. Number one, you're independent. So, WellSpan tends to be a little bit more of a closed market. Their doctors refer to their therapist and back and forth.
Yeah, no, it's right.
I like the concept that when you and I met, you mentioned that if I had a client go to you, and certain exercises were safe for them and certain exercises were not, and you're getting ready to discharge them. Knowing that I'm a personal trainer, you would be able to work with me a little bit.
Yeah, sure.
So talk to me a little bit about how you might coordinate with providers like us on taking that baton and moving it forward.
Yeah, that's pretty easy. Just very open communication between the providers is the easiest way, and myself, yourself, we're very easy to get a hold of.
Yeah,
just a simple phone call, email away, and I can call you for 3 minutes, be like, hey, John has this, and this, maybe try this, and then, and vice versa. If you need anything from me, I need anything from you. It's the open communication works the best. Whether it's
I love the open architecture because I think we both not primarily focusing on volume, but more smaller volume and quality. I think that's easier to do.
Nothing's worse than trying to get a hold of somebody and then get a phone call 4 days later.
Right.
It would have been nice to 3 days ago.
Yeah.
But the open communication is vital.
And to me, I think that's I put that to the test, not to test you, but rather I had a question about a client and a surgical history, and it wasn't even a client that you saw. I didn't share any personal information. I just said a person that had this condition or surgery, and you were able to walk me through what's safe and what's not safe, and you did that very, very quickly. And so I think to us, if we have clients that are our current clients, and they're thinking about, well, I got this nagging pain, to me, a real advantage of using Dyer and you guys is that if I call you guys, it doesn't matter, if you saw them a week ago, a month ago, I can share with you, hey, here's a condition. If I have somebody with this condition, what are, contraindications? What exercises are safe? You can get back to me on that.
You can reach out to me about anything,
Yeah.
Whether they're a patient up there or just a patient here, it doesn't matter. Just whatever's best for them. And,
Yeah.
Thank you.
Yeah.
For that, yeah.
So,
We have seen actually patients' weight loss plans stall due to pain. Quite frequently here, and patients would tell me, "Hey, my leg hurts, my back hurts." One of the requirements for us, we recommend you move 5,000 steps first month, 7,500 second. So it's kind of ingrained in the program, and we ask and press upon it. And some patients are unable to reach those due to pain and chronic ongoing lower back issues. So I'm glad to see that you're here and we can kind of address those.
yeah, for sure. Absolutely. Yeah, we can definitely work well together.
Yeah, and likewise, piggyback on that. Resistance training, when it comes to weight loss, obviously, if you have stronger muscles, if you have more muscle mass, more metabolically active tissue, The other thing that is interesting is some research has found that people that are resistant to losing weight, they call them weight loss resistors, they found that resistance training in particular benefits that population the most, And it's not that it's not resistance training versus cardio, it's not that, it's both. Both have a role to play. And backing up what he was saying, sometimes they can't hit their step goals because of, knee pain or, whatever, prior injury. And the same thing is sometimes, we can't give them a resistance training program because of these underlying injuries, And so it is good to have a partner with you. And for their own success, like if they want to have optimal results, if you want optimal results, it's resistance training, it's cardiovascular training, it's, our medical support, and then it's nutrition. If you have contraindications or impairments that are limiting a third of the program, it's not that you won't get results, but you're not going to get the top results. And long term, those lifestyle factors really become critical in maintaining your success down the road.
Sure.
So it's so much better to address those issues than to kind of like ignore them and put up with them and
you want to get out in front.
Yeah, sure.
Yeah, day after day.
Yeah, and having expert opinion close by, that's very helpful to us, so we're grateful for that.
Yeah, absolutely. So is there anything I should have asked you that I didn't ask you?
No, I think we covered just about everything.
Yeah.
Awesome.
With obesity being the way it is, we were just talking about it, we had the donor crossing that 50% of the population states is becoming obese, so and normal weight becoming almost an abnormal event anymore. So that's a very, very critical thing we can address. And I'm a true believer when it comes to obesity and depression. We have to throw everything at it, everything at our disposal. And of course, movement is, like you mentioned, Don, is the key component of maintenance. Not only it's important to lose the weight when it comes movement will become very important, but also maintaining
That's right.
when you get off of medications. And that's
right.
one of the things.
Yeah. In fact, that's where exercise really shines. A lot of people think I'm going to, it's the new year, I'm going to join a gym and lose weight. No, that's not how it works.
Right.
That is not how it works. But where exercise does shine, it will accelerate weight loss if there's other, measures put into place. It will accelerate it. But exercise by itself is not that great for weight loss. Research tells us that.
Yep.
What it is good at is maintaining a current weight.
Yep.
That is where it is good. And so, you have that habit when you lose the weight, and you keep that habit. Then when you're at your new, preferred weight, your lower weight, exercise will help you maintain it. So any impairments to that, that could be a real problem down the road in maintaining, hitting your goal and maintaining your goal.
So this is a pretty black and white question, but say out of 100%, how much of the overweight and obesity problem is immobility and diet? I know other medical conditions play a role, but...
Absolutely. I think nutrition tops almost everything in that category.
That's right.
It's a main culprit. And lack of activity, if you think about the first recorded heart attack in the United States was 1968. When in 1968, you used to, exercise to go to outhouse. just to go to the restroom. And we live in a farm. Since then, everybody has moved in a city. So, but even before that, having plenty of food was already an issue. So, I think in terms of having access to wrong, unlimited amount of nutrition and frequency we eat that is number one culprit. And then activity, it's almost like catch-22 follows. Now we see, for example, type 2 diabetes used to be called adult onset diabetes, but last 50, 60 years, it's inaccurate to say it because we see it in teenagers all the time. It's not anymore adult onset diabetes because teenagers have fat too.
Yep.
So in that sense, definitely what we eat is number one factor, and we address that.
Yeah, and it's interesting. I was reading some research in the 1970s was kind of the golden age of food science. They said, and that's when these ultra processed foods, where how do we trigger the brain? It became a research thing. How do we trigger the brain to crave more? What ingredients do we put together in what amounts? And what flavorings to get you to want to consume more. It was the golden era of food science, and with that came the ultra. And now you look at every corner's got Starbucks, mods, McDonald's, Burger King, Dairy Queen, all that stuff. It's just it's inside hospitals in many cases. It's in schools.
Yeah.
It's so all that stuff really started taking off in the 70s. And what's fascinating is in the 70s, in the early 70s, childhood obesity ran at about 5%. It's now close to 20%. People's genetics didn't change that much in that short, few decades. What changed was the environment. So, and specifically access, like he was saying, access to ultra-processed, super tasty, highly marketed, flashy packaged, cheap, brightly colored packaging to catch the eye, all that stuff, and that's, when researchers look at, well, what changed so dramatically, that's pretty much what changed the most.
It's as if the life we used to live, almost 1.8 million years as human race, is completely discontinuous. The radical environmental change for us humans last 200 years or so, because it is so different than what we used to do. Walk and eat and spend time with family. Now it's like we don't even do that anymore. That was our last victim.
So there's definitely a multitude of factors.
Absolutely. Yeah. So awesome. Well, appreciate you coming out here.
Absolutely.
Yeah, appreciate you telling us about Dyer therapy, and
Absolutely.
that's it. All right. Thanks so much. Okay, let's see if it recorded.
It did.